First, we will identify the McBurney's point. It is marked by a line joining the umbilicus and anterior iliac spine. The medial two-third and lateral one-third point is considered as the junction of McBurney's point. Here we will make incision that will extend one-third above and two-third below the McBurney's point to cut the skin, dermis and epidermis and dermis with a blade holding at right angle to the skin. Make an elaborative incision so that you can find out the appendix, as sometimes appendix lies deeper into the pelvis or retrocecal, or it could be subhepatic. Secure hemostasis, otherwise it will handle your filled and make you glow imperfectly. Now take a scissor and separate the subcutaneous tissue. We will face fascia camper. It is an extension of subcutaneous tissue and fascia scarpa. It is also considered as the deep fascia. Now we will incise the external oblique aponeurosis. Its fibers are running directly downward. We will make separation of the lift up the apponeurosis from the surroundings, so that in the future or after a closure, the sheath shall be properly closed. Otherwise, it would lead to formation of hernia, also known as inguinal hernia. We will dissect it with scissors all around from the muscles. Now cut in the direction of the skin, both sides, medially and laterally. Try not to cut the edges of the external oblique. Now hold it with artery scissors so that in the closure of sheath is very difficult at the end of the procedure. The only strength of the abdominal wall is external oblique apponeurosis laterally and thoracic sheath is anteriorly. Now we will dissect the muscles by deepening with and separating one artery forceps, opening it vertically, then inserting another artery forceps and opening it horizontally. We will go deeper and deeper until we see a glistening layer. You can see here a glistening layer. It is actually the peritoneum. Now we will separate the pre-peritoneal fat until we reach the peritoneum. The peritoneum appears as a glistening white layer. We will hold the space with right angle retractors. Now hold the peritoneum with one hand of artery forceps, then lift it up with another artery forceps. You can see here both the layers of the peritoneum are lifted up. Now make sure that you are in the peritoneum only by exposing the other end of the forceps. Now incise with blade, just give nick. Do not try to open it all, otherwise you will damage the gut lying below the peritoneum. Now pass artery forceps into the nick of the peritoneum or separate it bluntly with your finger. Swipe the finger all around in the abdominal cavity at 360 degrees and brought the appendix out. Now the appendix is in outside and we are holding it with babcock. Ligate the mesoappendix by making a window from the appendix base to the mesentery and tie it with vical 1, so that the artery of the appendix, also known as appendicular artery, the mesoappendix, shall be ligated and bleeding is secured. Do not cut the thread at all, just clamp it with artery forceps and use it as a lead point if any hemorrhage from the mesoappendix is occurred. Now hold the appendix with babcock and incise the mesoappendix just medial to the appendix. Hold it with artery forceps, the mesoappendix, and cut it with scissors. It will free the appendix from the mesoappendix. We have brought the gut outside just to make the view of the video clear. It is just for a video purpose because if the appendix is ligated intra-abdominally, we are unable to make the clear view of the appendectomy. Now, ligate the base of the appendix with vicryl and make it closed perfectly. Just hold the suture for about 5 seconds and apply a firm pressure. Make almost 5 to 6 knots and ensure that every knot is tight. Otherwise, during the separation of appendix, we will see the fecal matter coming out from the cecum. Because the interluminal connection of appendix is connected with cecum. We have ligated the base of appendix. Now we will crush the base with an artery forceps just above the suture. Hold it for 5 to 10 seconds. Now tie another suture at the base where we have crushed with artery forceps. The knots shall be cleared 5 to 6 and will be tightly firmed. Now cut the appendix just above the crushed area with the scalpel at right angle to the appendix. The appendix is separated. You can see the base where we have cut is now soaked with pyodine, so the fecal matter or the bacteria get destroyed and all the layers shall be closed sequentially to the skin.